Hi, and welcome to our September Cancer Prevention and Wellness Series program presented by the Cancer Survivors Park Alliance. Today we have Allison Bellomo, who is our speaker with us today. She's going to speak on the genetics of hematologic malignancies. Allison is a current genetic counselor within our Center for Integrative Oncology and Survivorship here at Prisma Health. Prior to that, she spent 10 years at Greenwood Genetics Center as a genetic counselor there. She holds a Bachelor's of Science from Furman University and her Master's of Science from the University of South Carolina Columbia School of Medicine. Thank you, Allison, for being here today. We really appreciate your expertise, time, and energy to speak with us on this topic.
Yeah, absolutely. I'm happy to talk about genetics. It's what I do every day, and I actually enjoy it. So hopefully there'll be some lessons learned that will be helpful for people.
Absolutely.
So the topic of the discussion today is the genetics of hematologic malignancies. And hematologic just is the fancy medical term for relating to the blood. And then malignancy is the medical term for cancer. So basically, we're going to be talking about the genetics of blood cancers. And I chose blood cancers because September is actually Blood Cancer Awareness Month. And awareness months are done because we're just trying to maybe spend a little more time focusing on something to educate and make people's lives better and related to that particular subject. So blood cancer is actually pretty rare, at least compared to other cancers like breast cancer or colon cancer or lung cancer. I think in the United States, there's about 178,000 new cases every year, whereas breast cancer, it's like 297,000 or more a year. So it is rare, and because it's rare, we don't know as much about it as other ones, but so trying to raise awareness and learn more about that particular type. I will say blood cancers, you might have heard of things like leukemia, lymphoma, myeloma. Those are all referring to cancers of the blood, and leukemia is typically the most common blood cancer. So just to kind of outline some main objectives that I would like to try to get through. First, just maybe understanding better the concept of genetic counseling and genetic testing. And then we'll kind of discuss who would benefit from genetic testing related to blood cancers, and then clarify some differences between genetic testing within cancer that can be confusing sometimes for people. So this is a diagram that if you've had biology might look familiar. If you haven't had biology in a long time, maybe not so familiar. But when we think about genetics, I think it helps to start back with the cell. And so humans are made up of trillions of different cells. We have skin cells, heart cells, eye cells, brain cells. Everything can be broken down into an individual cell. And it's inside each cell that we'll find structures that are referred to as chromosomes. And if you were to unravel, per se, the chromosome, you're going to see pieces of DNA attached to each other. And it's segments of that DNA that we would refer to as a gene. And an individual gene codes some type of instruction for your body to do some type of function that's important for your body to grow, develop, the way you look, function, everything about you. So the genes are the instructions for how our body should work.
So, is there anything that determines which genes are expressed and make it into that protein form? Are all genes expressed, or are only certain ones actually expressed within the protein?
Yeah, so that's a very great question and somewhat complicated. We know that in our bodies, say in a heart cell, there might not be genes necessary in that heart cell for a stomach cell. And so all of our cells actually have all of the same genes, all of the same DNA, but not all of that DNA functions in every cell type. So our bodies do have some way of turning on and turning off genes depending on what the purpose of that cell is. And a lot of that is coded in that DNA already. So a cell is kind of determined to be a heart cell. And so it turns on or off the genes that are not pertinent to it or the ones that are pertinent to it.
Yeah.
And that can be very difficult to explain. There's a lot of different things that can go on a molecular level to help control that gene expression. So genetic counseling is where we try to kind of answer questions like we just said, Rachel, where complicated genetic DNA study is then translated into what does this mean for a patient and how can this be important for a patient, their health, their family, or how can doctors use genetic information to help that patient or the family. And so right now, genetic counseling, it's a master's degree in genetic counseling. And so it's a 2-year program where there's a lot of instruction on genetics and genetic disease, but then also on genetic testing and interpreting genetic testing. And then again, kind of talking to people about how that can impact their health. So these are some maybe common reasons why someone might pursue genetic testing. Sometimes if we determine that there was a genetic cause for cancer, then it helps us understand why it happened. And honestly, for most people with cancer, we're not able to give a specific definitive answer as to why they got cancer. But if it's genetic, that can be a very important reason why, because they were born with something that predisposed them to cancer. Many of the genetic causes of cancer can also increase risk for other health problems or other cancers. So it can inform kind of future screenings or future risk reduction methods that a person could do. If a person has cancer and we determine it's genetic, sometimes that can play a role in what type of treatment the doctor would do, either what type of surgery or what type of chemotherapies they might prescribe. It can certainly help with the family. If it's genetic, that means it can be inherited. And so other people in the family might be at higher risk and may need to get access to earlier screening or frequent screening. It can connect people who have similar genetic things going on. And sometimes it can help us better, understand a diagnosis that we might not have understood otherwise. So this next slide kind of illuminates that even though we've so far been talking about genetics of cancer, that's a really rare and small part of the whole bigger picture of cancer. So most cancers are not what we would consider genetic or inherited. Only about 10% of cancer is known to be caused by a genetic or inherited risk factor, which means 90% are not.
What would you say a lot of the 90% would be? Is there categories or is it spontaneous? Is it environmental factors, exposures, lifestyle? Um, what kind of helps explain the 90%, if anything?
Yeah, so the 90% would be kind of a mixture of all those other things that you mentioned. So maybe a lifestyle related risk factor or environmental exposures and those sporadic random ones. So anything that's kind of not known to be inherited is put in that category. And there are several different reasons. And often a combination maybe of all of those factors in a person, not just their lifestyle, but also their environment, or maybe also that plus some kind of sporadic abnormality that pops up within a cell.
Yeah.
So if we get specific to these blood cancers, there are several different types of blood cancers, and you may have heard of some of these before and not realized they were a blood cancer. But leukemia, again, is the most common, and it's characterized by the rapid growth of abnormal white blood cells in the bone marrow. And that might often be picked up on just a regular blood count where they see that the white blood count is really, really high. Lymphoma is probably the second most common blood cancer, and it just has a different origin of the type of cell within the bone marrow, something we refer to as the lymphatic system. And that system in our body is important for producing the immune cells. A more rare blood cancer would be multiple myeloma. And again, it's just having to do with the origin of where the abnormal cell arises, the cancer arises in. And then an even more rare type would be myelodysplastic syndrome, or often called MDS. And that's just a group of different cancers where the bone marrow doesn't produce enough healthy blood cells. And a lot of times it progresses to an acute or sudden onset aggressive leukemia.
So are all of these really first diagnosed from a blood sample within more of like a primary care office, and then biopsied if that's sometimes the route the care team wants to take, or what's kind of the diagnostic workup for some of these?
Yeah, so I would say the leukemias and maybe the multiple myelomas and MDS, those most likely would be picked up on just routine blood testing. Sometimes if a person has fatigue that is just not going away with other normal ways we might think of overcoming fatigue, like getting more rest or exercising or better diet, and they go to their doctors, and a routine blood test might pick up, that there's a really elevated white blood count. The lymphomas sometimes can be picked up a little differently. Sometimes the lymphomas might create like what might feel like a mass in like a lymph node. And so sometimes those are felt as what feels like a mass. And then, to confirm, you would usually have to do like a bone marrow biopsy. So a biopsy of the bone marrow. So I know this can look very complicated, and it's complicated even for me as a genetics provider. So don't get too hung up on the complexity of this slide, but it just kind of is trying to show you that our bodies start out with what we might refer to as like a stem cell, like a bone marrow stem cell, represented by that blood stem cell you'll see in the middle of this slide. And then from that one cell, it could kind of what we call differentiate into two different types of cells. And then even that cell can get more specialized into its function within the body. And that myeloid stem cell that comes from the original one, that's where we're going to see more of the cancers that can be inherited. We don't really fully understand why, but of the ones we've discovered so far with known genetic predispositions, they almost always fall into that myeloid category. And myeloid just means from the bone marrow. The lymphomas, the lymphoid side, there's just, even though we've done studies to try to figure out genetic causes, even in families where there are multiple generations of people with lymphoma, multiple relatives with lymphoma, we have not been successful in pinpointing a specific gene or genetic cause for those families. So these acute leukemias, the MDS, those are more likely to have a genetic component than lymphomas. We don't really have genetic testing available for the lymphoid line of blood cancers.
And genetics is always an evolving field, so it's good to know that we're continuing to learn more, every single year about how genetics plays a role in cancer in general. So,
yeah, absolutely. And even these, the myeloid ones, I would say before around 2019, we didn't think they were genetic. We were like, oh, those aren't hereditary. And really around 2019 was where it started to come more to the forefront of clinical availability to test for genes for that. So could still change in the future. So kind of going back a little bit to what we were referring to before, that most cancers are not genetic, and therefore most of them are caused by just mutations that may pop up randomly in one of those bone marrow cells. Hereditary cancer is not a random genetic mutation that pops up sometime in someone's life. It's rather when you're born with something that you inherited from your parents that predisposes that stem cell, that bone marrow cell, to turn into a cancer. So you're kind of born with this increased risk. And it's those that we're going to talk a little bit more about today. There's now more than 16 genes that we know of that can predispose someone to a blood cancer. And like I just said, the testing for this really started to become available around 2019.
So, say somebody does, in fact, test positive for a gene that has been shown to increase risk of a blood cancer. Would that help with getting more testing more often? Would that allow for insurance to help with some of the testing? What is kind of the you know down the road effect of a positive diagnosis within screening?
Yeah, and it can depend on if we're doing genetic testing because someone actually already has a blood cancer versus if we're doing genetic testing on someone who is healthy but has a family history. And so they're wondering, could they get it in the future?
Mhm.
And most of the information we have right now is related to people who already have a blood cancer and how that can affect their treatments. There's certain chemotherapies that are known to be more toxic if you have one of these hereditary mutations.
Mhm.
We would not recommend a related donor for someone with a genetic predisposition because that relative could also have that same inherited broken gene. So we don't want to use kind of a bad bone marrow from a relative to replace an already bad bone marrow.
Mhm.
As far as if someone doesn't have cancer and we're doing it because we want to be smarter about kind of future risk,
Mhm.
it could probably make people more apt to get a blood count more regularly. There's some studies out trying to determine should a healthy person with no symptoms, still get a bone marrow biopsy, which can be a pretty invasive procedure. There's some recommendations for that by certain organizations, but it's not a prime time thing yet. It's still mostly being more educated on early signs and symptoms and making sure that at least an annual blood count is done for those people.
Got it. Yeah. And insurance is that affected at all if someone were to test positive?
Yeah, so with insurance, there are federal laws that say health insurance companies are not allowed to use a genetic predisposition to drop someone or not cover their health insurance or even increase their premiums. So there are federal laws in place to prevent that. And it's not 100%, but in most cases, if you have a genetic predisposition, insurance is more likely to cover the extra screenings or risk reducing methods that are recommended for that gene.
Thank you.
So if we were to kind of just mention some of the genes that were discovered related to these inherited blood cancers, you'll see them listed there on the left. And genes can have really weird names, often named by the protein that the cell makes from that gene. And so the first one, we refer to that as RUNX1. There's a GATA2, DDX41. But all of these genes are genes that all of us have. Every human has these genes. We actually have two copies of them. We have two copies of all of our genes because half come from our mother and half from our father. And these genes are normally doing an important function within that cell. And it's when you're born with an abnormality, what we would usually refer to as a mutation in one of these genes, that then makes that gene not able to do its job, that puts that person at higher risk. So inherited cancer doesn't mean you're born with cancer. If you have a positive genetic test, it doesn't mean you have cancer. It just means you were born with a non-working gene. And because of that particular gene not working, it's putting that person at higher risk to develop cancer. And the type of cancer depends on which gene. And so these particular genes are ones we know specifically increase the risk for a blood cancer. Oops. So when should a person consider getting tested for these rare genetic causes of blood cancer? Usually we're more concerned if one of these blood cancers is happening before the age of 50. So a younger diagnosis of leukemia is going to be more suggestive of a genetic predisposition than someone who's already in their 60s or 70s or 80s when they develop that blood cancer. As you might guess, we would usually expect there to be family history, so other people in the family with leukemia, and not necessarily like, oh, well, my dad has it and my mom's sister. That wouldn't be as concerning as if your mom and your mom's sister. So it's kind of the blood cancers all on the same side of the family is more suggestive that it's linked to a gene coming from that side. So not a lot of times people think, oh, well, I have cancer on both sides of my family. It's actually more concerning if it's all on one side as far as a genetic concern. Certain types of the blood cancer, so that MDS, the really rare one, is a little bit more likely to be genetic. I think any age of MDS is recommended for genetic testing. So even if you're older, if you get that type or have that type in your family, and then also the AMLs, the acute myelogenous leukemias, are a little bit more likely to be genetic. And then some of these genes that cause blood cancers can also cause what we call solid tumors. And so those would be cancers in like your organs. So some of these can also cause breast cancer, can also cause other cancers. So if you see a combination of blood cancers and really young ages of breast cancer, that could also be a clue. So those are kind of when we would actually think genetic testing should be considered. Maybe ask for a referral to talk to a genetic counselor if you have these things going on either in yourself or in your family. So this just kind of lists when it's maybe not so helpful, like when we're maybe less likely to actually find something genetic. So again, if the diagnosis is when people are older, or if it's just one person in your family, those lymphomas we talked about there's just not good genetic testing for that right now. And then the chronic leukemias are less likely to be genetic than those acute. And so acute means there's kind of a sudden onset that's a really significant, needs treatment right away. Chronic would be ones that can be maybe watched over time to see if they get worse, and people can live with a chronic leukemia for a long time, sometimes without treatment. So some of this we may have alluded to already, but kind of why is knowing that there's a hereditary cause important? One is that identifies you as higher risk, which may mean we need to monitor you differently or treat you differently if you get diagnosed. And then many of these genes that cause blood cancer may also put that person at a higher risk for other cancers that they may have not already be monitored for. It can impact the screening and the treatment, can help family. And as we mentioned before, like kind of who you choose as a donor, you wouldn't want to choose a relative if there's already a hereditary component going on that's putting the risk of blood cancer higher. So what happens when you go see a genetic counselor? Often the first part of talking with someone is that genetic counselor needs to kind of comb through your medical history and your family history. So if you do get referred to a genetic counselor, try to be prepared to answer questions about who has cancer in your family and what type of cancer and how old they were. And, be as specific as you can as far as, blood cancer. Well, was it a leukemia or was it a lymphoma? Was it acute or was it chronic? We don't always know those things because we don't think to ask. But if you can and know that before you come to genetic counselor, it helps us a lot. And then based on the information about the types of cancer and who has cancer, we can make some recommendations about what genetic testing should be done, if it should be done. For blood cancers, there's one kind of unique situation we have to think about. And people who have a blood cancer, we cannot use their blood to look for genetic mutations. One of the defining characteristics of cancer is that those cells are mutated. They have mutations in them. And we don't want to pick up the cancer mutations when we're doing hereditary testing. We only want to know what were they born with, not what's become abnormal over time. And that can be really hard to differentiate when the cancer's in the blood. So if we're testing the blood, we might pick up non-inherited mutations. And so we often have to do what's called a skin biopsy. And so we use cells obtained from the skin and get DNA out of those cells rather than from DNA from the blood. If the person's unaffected, they don't have cancer, and they're doing genetic testing just because it's in their family, we don't have to worry about that. It's only if the person themselves has an active blood cancer. And then when the results come in, we help try to understand what was found and how does that explain what either the person has or what's been going on in the family, and use that to maybe better understand risk for other things in the future. And then how does that affect the family, and then offer support and resources and referrals to providers that can begin to monitor them for the problems that can be seen with that gene.
Yeah. And for those that don't know, Prisma here, the Center for Integrative Oncology and Survivorship, Allison's one of three wonderful genetic counselors we have. And you guys all do such a good job of really offering the supportive resources. All of this can be really intimidating. Some people just don't want to know about their genetic predispositions. Some people feel like this is a lot to take in, and those results and the way you guys process that with the patient is really, really important, and you guys do such a good job. So thank you for that kind of work, in addition to the scientific expertise you offer. Definitely
Absolutely.
that care and support is huge.
Thank you. And I might be biased because I am a genetic counselor, but all genetic counselors are just a really unique profession where we can mix the science with the psychosocial, bringing it down and caring for the patient. So I think all genetic counselors do a really great job with that.
Yeah. Do you guys have specific panels that you offer here at Prisma, or might be offered other locations as well that specifically target these blood cancer related genes?
Yeah, so there are, hundreds of different genetic testing companies.
Yeah.
Um, Not all of them are equal. Many of them are good, but then even the ones that are good kind of have different offerings for what genes are included on their panels. And so that is part of the genetic counseling process, is finding out which lab is most appropriate for the patient, not only for hopefully the genes that are appropriate, but cost effective for the patient as well. So typically, at least for now, the labs that we would use that have the best kind of blood cancer panels would be Invitae, and they're also probably the most cost effective. We use other labs for our breast cancer panels, but we do have to kind of pay attention and make sure that the genes we're worried about are included on different panels. Definitely, your direct to consumer testing like 23andMe are not going to be looking at these genes. They would not pick up something related to many of the hereditary cancers, which can be a misconception that if you have a normal 23andMe, then you're not at risk or you don't have the genetics. But they are very, very limited in what they're actually looking for and are not comprehensive enough.
Yeah. What kind of referrals would you offer if someone were to test positive for one of these blood cancer related genes?
Yeah, right now we would probably refer them to hematology oncology. to have them monitor for any signs or symptoms and educate about what those signs or symptoms would be. If it's a gene that can also increase the risk for other organ tumors, then we do have a genetics management clinic at CIOS here at Prisma Health, where a nurse practitioner would meet with that person usually annually to go over all the different cancers associated with that genetic finding and make referrals or order exams or screenings or tests appropriate for the risk for that cancer gene.
Thank you.
Yeah. So this is just an example of what we call a pedigree. And so it's part of that initial intake. The genetic counselor is going to draw out a pretty detailed family tree, and it helps kind of visualize multiple generations at once. The squares are males and the circles are females. The diamonds that you see in the middle for you would just represent if we didn't know if the person was a male or a female. And each kind of line there represents a different generation. And so we could kind of mark who has cancer and what type, and it helps us kind of look for patterns or clues that suggest this inherited risk. So once those results come in, there are typically 3 different possibilities when someone gets a genetic test done for hereditary cancer. One possibility is that someone tests positive. And again, this is the most rare, because positive would mean there is an inherited genetic abnormality, and those inherited causes of cancer are, again, rare. But this would mean that a person was born with an abnormality in a gene that makes them more likely to get cancer. It can inform what type of screening or surveillance or treatment they might need to get. And it allows us to use a blood test to see who else in the family inherited that same risk factor and make sure they have access to prevention and screening. It's very possible, and actually most common, that people get a negative result on their genetic test. And a lot of people think, well, if I have breast cancer, I've got the gene, or if I've got cancer, of course I have the gene. And that is not true. Most people have a normal genetic test. We don't usually find that there was an inherited genetic abnormality because, again, those things are just rare. And this reduces the likelihood that it's a hereditary thing. That reduces the likelihood that there would be other cancers, or either in that person or in their family. It doesn't completely go away because we don't know everything. And so we only test the genes that we know of, and maybe in the future there's other genes that we just didn't even know to look at. So we have to be cautious that negative doesn't mean absolutely not genetic, just not based on the testing we have available to us right now. And then the second most common result are results that we call uncertain. That means that the laboratory found something different, a change or a variant in a gene, and we just don't know enough if that variant is breaking that gene's function, or is it different but still allowing the gene to work. So we can have differences in our DNA that don't actually cause disease. In fact, all of us have differences because we're all different people. And so laboratories have done a really good job over time of determining, well, what differences are mutations and what differences are benign, but they can still come across differences that haven't been seen enough, where they're not confident about the effect of that difference on the gene's function. We treat these uncertain results as if they are normal. So it is not recommended to use an uncertain finding as a diagnosis of genetic cause of cancer. So since we've kind of been focusing mostly on these inherited causes of cancer, these are just some more kind of narrowing down on points to think about with hereditary versus not hereditary. So a hereditary cancer, again, is caused by inherited mutations. And that means the mutation is present from conception. So the first egg and sperm cell that come together, that mutation was already present in either the one from mom or dad, the egg or the sperm. And that usually means it came from the parent. It was inherited. And since it's in that very first cell, if you remember, we said all the genes are the same in all of our cells. And so that mutation is present in every cell of that person's body, not just in the cancer cell. And because of that, it can be passed on to children, to offspring. So it's not just in the body, but it's also in the sperm cells or the egg cells that a person has. And because it's in all of our cells, we can use tissues like the blood or saliva or skin biopsy, like I mentioned, to look for this mutation because it should be present no matter what cell type we are using to look for it. And so that is in contrast to these cancers that are not hereditary, because we still will expect mutations to be present in a cancer cell. Because again, part of the definition of cancer is that there's mutations in that cell. But those types of mutations are what we consider acquired. You are not born with that mutation. It just popped up in one cell later in life. And the mutation is only present in a small subset of cells, kind of the ones that are considered the cancer cells. Mm-hmm. And that would not be something that you would have inherited from your parent. And if it's only in that cancer cell, it's not in your egg cells or your sperm cells, and therefore it's not something you could pass on to your children. And to find these types of mutations, we can't just use necessarily the blood or the saliva. We have to test the cancer cells. So a lot of times people will have genetic testing done on their tumor tissue. And this is the same for blood cancers. Hematology oncologists will order on a bone marrow biopsy genetic testing of the mutations in that bone marrow. But that does not represent necessarily what a person was born with, but rather just what mutations have popped up and accrued in that cancer cell.
Yeah, that's a really good differentiation between these two, because that's obviously a very confusing concept, the fact that we have two types of genetic testing there. And really knowing the difference between them is a really powerful thing. So thank you for explaining the differences.
Yeah, and it can certainly be confusing because doctors refer to both as genetic testing, and so you might think, well, I already had genetic testing if they already tested your tumor, when you didn't really have the hereditary testing. So they're both important, but they're not the same. Yeah. So to try to explain a little bit more, in that this top scenario are what we expect if there's a non-hereditary cancer that pops up. And so you'll see those blue circles with the two white lines. Those lines represent chromosomes. And remember, we have two copies of each chromosome, one from each parent. And so in a typical case, we would expect both parents to have normal genes. And therefore, the person inherits two normal genes. But somewhere along the line, in just one cell of the body, mutation happens. And that might not be that bad. Your cell might still be able to function and do its job just fine. But somewhere along the road later, a mutation happens in that same gene on the opposite chromosome. And then we're in a situation where for that particular gene, there's no functioning copy of that gene. So both of them don't work now. And that can send the cell into a cascading event of just abnormalities perpetuating, and it can grow into a cancer. And so that would be the somatic mutations and the kind of non-inherited mutations that cause cancer. Whereas on the bottom, the hereditary scenario, we would expect that a parent already had an abnormality in a gene. And it's important to know, too, that you can carry an abnormality in a gene and never get cancer. And so just because your parents might not have cancer does not mean that they don't have a genetic mutation. So not all genetic mutations cause cancer. They just raise the risk. But in this scenario, from the very beginning, that one of the abnormal genes is already inherited. And so it only takes one other mutation before the cell turns into a cancer. And so that's why there's a higher risk, is that you're starting out with something already abnormal. And it doesn't take necessarily as long, which is why many people with hereditary cancer get diagnosed with cancer at a younger age than typical. So I know that can be somewhat complicated, but it's a diagram that tries to show the inherited difference from non-inherited. So this is kind of a pretty famous saying within cancer genetic counselors, that all cancer is technically genetic. We're talking about DNA mutations, but most cancer is not inherited. Okay, so unlikely to actually identify that from the very beginning there was already an abnormal gene. So to talk about that somatic testing a little bit more, this is, again, things that aren't inherited, things that are kind of random or just in the cancer cells. And so somatic testing is looking at mutations that came from the environment or lifestyle or just from being human, that developed over time. And that can be very important for cancer doctors to understand maybe how aggressive a cancer might be, or if there are targeted therapies, drugs that were developed to attack mutations, certain types of mutations. And there's lots of different companies that do that. So if you hear from a family member or have had it yourself, Foundation One, Tempus, Oncotype, Mammoprint, those are genetic tests, but they're not hereditary genetic testing. This next slide is just an example of the skin biopsies that we have to do. It can somewhat make testing take a lot longer for those people who have to have a skin biopsy. So mostly are people who are already affected with a blood cancer, and we're trying to figure out if it was genetic, and we can't use the blood or the saliva. There's actually blood cells that can float around in your saliva that would be those somatic mutations that we catch instead of the hereditary ones. So we have to have a skin biopsy procedure done, and that can be done in the office, kind of like how we might have a mole removed. It doesn't require sedation, other than just numbing the skin. But it can take pretty quick to do the procedure, but then they have to grow those cells in the lab. And that can take like 8 to 10 weeks for labs to grow enough of the skin cells to then extract enough DNA to use for the actual genetic testing.
And this is for those that have an active blood cancer, correct? So this
That's
would
right.
be a tool to better inform the care team of treatment and further down the road knowledge.
Yeah, and for the family members too. But we wouldn't, if we identified a genetic mutation, inherited mutation, in someone who has blood cancer through the skin biopsy procedure, and then we knew that their children were at risk or their siblings, we don't have to do a skin biopsy on those relatives who don't actually have an active blood cancer. So it's just if we're concerned that we might pick up those somatic cancer mutations rather than something that was there from conception. And that can complicate things if the cancer's in the blood and we're using the blood to look for the inherited mutations too. Because the testing kind of can't determine when it sees a mutation if it was there from conception or if it's just part of the acquired cancer mutation. Can't differentiate. And I think that was kind of the end of the things I wanted to discuss. I don't know if there were other questions that came to mind, Rachel, that we didn't get to go over. Or...
Well, thank you, Allison, for joining us today for our September Cancer Prevention Wellness Series. We're so grateful that you were able to educate us on so many important topics within genetics and specifically within hematological genetic counseling. So thank you again for joining us. Really, really appreciate your time and expertise on this topic that is complicated, but you did a really good job
Thank
of
you.
bringing it down for everybody to basically understand. Want to end with a quote. We have a quote from Nelson Mandela: "Education is the most powerful weapon which you can use to change the world." So that is a good one for today because Allison really did a good job of educating us there. Please join us next month on the importance of sleep with Dr. Amy Curtis from Spartanburg Regional. We're very grateful to have her on our talk for next month. Thank you so much, and we'll look forward to seeing you next time.
Thank you.